Good evening. Folks, I know you're still eating, and that's fine, and still, while the buffet is there, make sure it goes to good use. My name is Leonard, and I'll be the moderator of our session this evening. I'm the president of the National Pharmaceutical Council, and we are a DC-based health policy group just a few blocks away from here, and we're very pleased to be sponsors, one of the sponsors this evening, and also kind of helping to lead this discussion on biodiversity and healthcare qualities, 21st Century Challenge. And before we get going, and we have a very esteemed panel we're going to hear from, and then we'll engage in some Q&A to get everybody involved in the conversation tonight. But I first want to thank the National Minority Quality Forum and Gary Puckrein for their leadership role in this event, as well as the Congressional Black Caucus Braintrust. And we're very pleased to have the chair of the CBC Braintrust here, Congresswoman Kelly. Thank you for joining us this evening. And April, as you know, is National Minority Health Month. It's an opportunity to raise awareness about health disparities, and that's what we're really going to focus on tonight with our conversation. It continues to affect racial and ethnic minorities in this country, and to focus attention on strategies and efforts to advance health equity. My organization, the National Pharmaceutical Council, did a conference a little over a year ago we called it the Myth of Average, and on your table there's some brochures about that, and if you get an opportunity, feel free to take those home. But I think for us, that was really how we got engaged in this topic, and I'll go into this in a little more detail in a few minutes. But we're going to try and speak efficiently tonight so we can get to some Q&A, and I know it's already been a long day for folks, but we're going to get through this topic because it's a very important topic. I'm going to have really just 3 key points to set the stage for the conversation, and then we'll hear from our experts. First of all, no news flash to anyone in the room, but we are all unique individuals. And the uniqueness of every individual and every patient is not always reflected in research. It's not always reflected in the studies that are being conducted, and ultimately in the treatments that are prescribed for individual patients. And these differences matter terrifically. The good news is that we do live in exciting times, and there are new cures that are coming and curing diseases which have been previously horrible or chronic diseases that have lasted a lifetime, and now they can be cured. Or other progress that's being made in cancer is very exciting. It's a very exciting time. And people are living longer than ever. So we have lots of tremendous science that's happening, but there are also still challenges. There are great disparities in healthcare, and we're not doing enough to account for the diversity among patients. And the access issues are still troubling. There's still a lot of folks who can't get access to the medications they need or the treatments that they need on a regular basis, and that's very problematic. So as I mentioned, we have a terrific panel that we're going to hear from, and I'm going to try and truncate their bios because they're all very significant folks, and they have done a lot of great things in their careers, but I'm going to try, without doing any disservice, to capture the panelists that we're going to hear from tonight. Dr. Daniel Mullins, who we've had the pleasure of working with in the past, and he worked on this conference that I just referenced a few minutes ago, is a professor in the Pharmaceutical Health Service Research Department at the University of Maryland School of Pharmacy. His research and teaching focuses on pharmacoeconomics, comparative effectiveness research, which I'll mention and talk about in a couple of minutes as well, patient-centered outcomes research, and health disparities research. In addition to his faculty appointment, Professor Mullins also serves as Associate Director of the Center on Drug and Public Policy at the School of Pharmacy at Maryland, and is co-editor of Value in Health, which is an esteemed publication in the health services research community. Next will be Dr. Gary Puckrein, President and CEO of the National Minority Quality Forum. And at the forum, among many accomplishments, he has built an in-house capacity for vital statistics and other information in a centralized warehouse, and has also developed the forum's health indexes and atlases to measure and forecast health status in small geographic areas, evaluate the impact of specific interventions, monitor changes in health outcomes, and provide information and analysis regarding the health of ethnic and racial minorities. Our next speaker will be Dr. Georgia Dunston, who is full professor and former chair of the Department of Microbiology in the College of Medicine at Howard University, is also the founding and interim director of the National Human Genome Center at Howard. She has an incredibly vast research experience and expertise in human immunogenetics and human genome variation in African Americans and other populations of African ancestry. So we look forward to her comments tonight. And finally, batting cleanup for us this evening will be Adolph Falcon, who is Senior Vice President at the National Alliance for Hispanic Health, where he currently oversees the science and policy portfolio. He serves as principal investigator for the Alliance Merck Ciencia Hispanic Scholars Program, a scholarship and internship program to increase Hispanic participation in science, technology, engineering, and math, the STEM program. So we'll hear from them in a minute. I'm going to try and speed through this kind of setup that I want to share with all of you, but I do think it's important to kind of level set where we're coming from and what we wanted to share with you and talk with you about tonight. So, comparative effectiveness research, this is an area that Dr. Mullins is a noted expert in, but my organization has been tracking this issue for the last several years and has been engaged with a group called the Patient-Centered Outcomes Research Institute, which many of you may know, and their charge is to fund research in the area of comparative effectiveness, which at its fundamental core is about comparing treatments and comparing ways to deliver healthcare and communicate about healthcare and identify the best methods for doing so. They have a lot of money to do this, and they've been sending out grants to the tune of $730+ million. NIH is also involved in this area, as is the Agency for Health Research and Quality, AHRQ, which have together over $675 million in available funding. But it's not as simple as simply comparing treatment A versus treatment B, because if you just were to measure treatment A against treatment B, in many patients, the majority may respond better to one particular treatment, but the minority or another group may respond better to treatment B. Well, and we were concerned about government moving all of its chips onto treatment A, for example, and then folks who respond better to treatment B are left out in the cold, if you will. So because not every individual responds the same way to various treatments. So that's a very important component of comparative effectiveness that we have been tracking. Another way to look at this is if this particular study, this is a piece of work that was done on behalf of our organization, but if all of the patients in this scatter chart, if you could see, received the blue pill, then the individuals who respond better to the red pill would be disadvantaged because they wouldn't be getting the optimal treatment for them. So we ask the question, what is the average patient? Well, we think that it is a fallacy to even maintain that there is an average patient, because there really isn't. We're all individuals. This average patient is actually a photo generation of all of these other folks that you see on this screen. So that's what you call a morph or a Photoshop of all of those individuals around the screen to make that one person who looks like the average patient, but they all respond differently. And of course, the causes of this, the causes of this heterogeneity of treatment effect, as we call it, are many and numbered. Age differences, gender differences, ethnicity, the severity of the disease, care and comorbidities, environment, the diet, everything can go into effect, and genetics, of course. And so very quickly, I mentioned Puckrein and some of the work that they're doing. And the full name of the organization, Patient-Centered Outcomes Research Institute. I think the good news is they are really taking that patient-centeredness to heart. They have been really focused on making sure that individual patients and the patient organizations are a part of every study that they fund. And I know Dr. Mullins is going to speak a little bit more about that in a minute. You also have some other very exciting things going on. The 21st Century Cures legislation has been introduced, or has got some traction in the House, and I think we'll be hearing a lot about this legislation through the course of this year. And it does build on patient-focused drug development program, which is very important to get minorities involved in clinical trials much earlier and in much higher preponderance. And then the Clinical Trial Engagement Network, and this hats off to Gary and to the Quality Forum for the work that they have done in partnership with pharma to encourage participation of minorities and people from all different backgrounds in clinical trials. Very important work, and I hope Gary will speak about that in a little more detail. And then finally, the Precision Medicine Initiative. Now, the President pulled this out of his State of the Union and mentioned this deliberately and specifically pointed to the importance of precision medicine, personalized medicine, and this massive database that he wants to build within the NIH, and $215 million being invested in this endeavor, which I think is very exciting, and that will get us closer to custom care or precision care for each individual patient. So those are the topics that we're going to kind of rattle around in tonight and have a conversation, and I hope that it can be a town hall where we get to engage and have some dialogue with the folks sitting here tonight. But I want to give everybody an opportunity here on the panel to tell us a little bit about what they're working on. I'm going to start with Dr. Mullins, and you can take over, Doctor, and I know you'll share some of the work that you're doing at the University of Maryland.
Great, thanks very much. Okay, thanks very much. So, intuitively, we all know that each of us does respond differently. I work in a school of pharmacy, and we know that the same drug in two different individuals will have a different response. In the scientific community, we refer to this as heterogeneity of treatment response, or heterogeneity of treatment effect. And so we sought to answer a simple question. If you go to existing literature, is there evidence at a sufficient level that would allow us to know what causes those differences, right? We live in an evidence-based world. I want to begin by acknowledging National Pharmaceutical Council for funding of this study, and also all of my collaborators who worked on this. So the first is Dr. Mindakiri, who was a hospitalist fellow who worked with me, my graduate student, the medical oncologist, Dr. Hussain, was on the project, the methodologist, Dr. Nukwa, and my two colleagues at the MPC, Daryl Pritchard and Bobby DuBois. And if you're interested in this, this has subsequently been published in the Journal of Comparative Effectiveness Research, which is a new journal that looks at these issues about how patients like me respond to treatment. We decided to go with stage 4 prostate cancer because we know that there are a lot of differences, and there are reasonable treatment options here where we've observed different outcomes across patients. And so our question was, would we be able to find both biological as well as non-biological factors that have an evidence base that suggests that if you give a person a treatment for their stage 4 prostate cancer, that would influence their outcomes. And our conceptual framework was that there are both biologic and non-biologic factors, but that those non-biologic factors are also influenced by the environment, both the general environment as well as the healthcare environment in which a patient receives their care. So we have patient-level factors, but we also have provider and system-level factors as well as environmental factors in general. And that all of these could, both affect what treatments you get as well as the effect of that treatment across individuals, and wanted to find out what we could learn about this. So we did a systematic review of the literature looking for factors that would predict differences in the response that a man would have to some treatment for stage 4 prostate cancer. In the end, after looking about 1,000 articles that we identified in Medline and PubMed searches between the beginning of time, so to speak, 1946, and the last month before we started this project, we eventually came up with 92. And the first thing you'll notice is that of the 92 articles, 87 of them focused on biologic factors. So this looking for precision medicine, looking for biomarkers, looking for basic science to provide the answers. There seems to be more evidence in the literature along those lines. But we did also see 5 articles that looked at social factors, geographic factors, things like diet that we know also influence outcomes. If you look across these studies, most of them were done in the US. Second was Canada and followed by Europe. 16 were multi-regional studies, so they went across different countries. And about half of them were trials and half of them were what we call observational studies, or using existing data sets to look at factors that influence outcomes. What was a little disappointing is that when you looked at those 92 articles and you used a commonly accepted criteria for judging the quality of the article, which is an indicator of the quality of the evidence, the vast majority of the articles would be, according to the Agency for Healthcare Research and Quality's definition, of fair quality. And by fair, I don't mean favorable. I mean less than good. And only 15% were good, and another 16% were of poor quality. So you know, the best news is that 15% of articles are good, and then we go down from there. Most of the articles, since we were looking at stage 4 prostate cancer, it's not surprising, we're looking at hormonal therapy, mainly ADT, but other forms of hormonal therapy as well. Not surprisingly, the most popular outcome was overall survival, and in many cases that was the only outcome that was studied. But there were a small number that looked at health-related quality of life issues. So again, most of these articles are looking at the traditional clinical measure that we're always most interested in, which is overall survival. Even in the front row, you can't read this, but I'm hoping that when you look at that, you realize that there's a lot of evidence out there. There's a lot of evidence out there. Each of those boxes is a category of variables that we found in the literature. And all of the print underneath that you can't read, but you can look at the article if you're interested, are the individual variables that are in the literature. So there's a lot of information, but you'll remember that what I said is the quality of these articles isn't very good. So we have a lot of information about what might cause a variation, but we can't be very confident that those are the actual factors that are predicting it. In fact, when we look at the number of times that something's studied, we look at how it's rated, and we look at the direction of causality, we sometimes even see that the literature is conflicting. So you may have a study that suggests that something is both positively correlated with overall survival in one study and negatively correlated with overall survival in another. Right? You probably heard my background is in economics. We're known as dismal scientists, and so for those of you who kind of have had the pleasure of working with an economist, you know that we are known for kind of bringing bad news. So I want to make sure that you don't leave thinking that it's all bad news, though, because this was essentially starting a conversation about, is there information out there, or do we need to do more research? And so what I would say is that right now, because this concept of looking for factors that predict differences in treatment response is a relatively new thing that we're doing in science. And so it's not surprising that it's, you know, not easy to find these articles. If you use the scientific term heterogeneity of treatment effect, you probably won't find what you're looking for. So in some ways you have to know what you're looking for at this point to find it in the literature. I think that the example that we used of stage 4 prostate cancer is probably a pretty good example, and my fear is that if we went into other therapeutic areas, the evidence would be even worse. When we do find information about differences in treatment response, it's usually something that's a secondary concern in the article. You know, the primary concern is, does a technology improve health? And then the secondary objective is, oh, and is there difference in the extent of benefit or harm? And so if we're looking for differences, we're going to have to accept the fact that this is probably a secondary consideration in most of the work that's been done to date. Even when people look at subgroup analyses, they don't necessarily look at differential treatment response, right? And this is a problem that sometimes we observe, for instance, that there's a difference in African Americans than there are in whites, or there's a difference in elderly patients than there are in younger patients. And sometimes people assume that that's the effect of the treatment, when in fact that could just be that the treatment and that condition are both correlated with the outcome of interest. And what we really want to know is there a differential treatment response, right? And so it's entirely possible that elderly people will live longer than younger people, and yet they might get more benefit from treatment. And so it's really important as we evolve this science that we use statistics in the right way, and that we don't simply look at whether somebody lives longer or not, but we look at what happens when they receive a treatment as compared to when they don't receive a treatment. And sometimes the most at-risk individuals could receive the best benefit if we found the right treatment for them. And that's the important thing for us to remember as we look for differential treatment. Well, as we move forward, we want to think about the lessons for patients. The lessons for patients is that we can help to find the right treatment for patients like you, and assume that you are not the average patient, and we can help you make more informed decision. For providers, we can help providers to understand this concept of differential treatment response, not just different outcomes, and really study what causes a treatment to work differently in different types of patients. And then finally, for policymakers, and payers, we know that the FDA has this new interest in understanding how should we study when a new drug is coming to the market, when a new device is being tested. Not only whether something works, but the extent to which it works in different groups, and provide additional information so that patients can make more informed decisions, that they can talk with their healthcare providers and have a conversation about what's the most effective treatment for them, recognizing that patients are never average. And finally, that for those who are paying for medicines, whether it's the patient out of pocket or whether it's insurance company, that they'll have the evidence that they need to make sure that they cover what's most effective for individual patients. Thank you.
So I want to talk to you about this from two vantage points. One from the reimbursement standpoint, and the other from clinical research. So for those of you like myself who are patients in the healthcare system, what you may not realize is that there is, and I'm sure you've heard it, we no longer want to pay for quantity, we want to pay for value. We want to move away from, we want a value-based healthcare system. So what's been going on is that certainly CMS and the Medicare program and Medicaid program and commercial insurers have been developing performance measures. So performance measures, the way they typically work is they take the universe of all patients. Well, let's take heart failure, because we talked about that a little bit this afternoon. So the universe of all patients would be any patient over the age of 18 that has chronic heart failure. And so what the performance measure would say is, inside the clinical guideline, the recommendation is that a patient should get either an ACE or an ARB. And so the numerator that would be used is, did the physician give you an ACE? Did the physician give you an ARB? And when we look in the aggregate across all of the physician's patients, if 80% of his patients or more got an ACE or an ARB, then the physician would get a bonus reimbursement. We'd pay him more. If the physician provided less, then we would deduct that from his pay. And that's quality. You don't know that, but I'm telling you, that's what's going on. You think when that doctor wrote that script is because he liked you, right? No, I'm telling you what's going on, right? The problem is, in that particular instance, for African Americans, that's not standard of care. If you went over to the clinical guidelines and read the clinical guidelines for the management of heart failure, it would say for African Americans, we need to give them some additional therapy, right? That's what the guidelines say. So guidelines, clinical guidelines and performance measures, how we reimburse physicians, is a very, very different thing. In fact, performance measures don't necessarily even have to adhere to guidelines, the clinical guidelines. You didn't know that, right? But that's what's going on. And the problem with that is, and I understand why it's happening, because payers, and speaking in the general terms, they want to set up metrics. They want to create, they want to understand value. They want to move away from quantity to value. But even more importantly, they want to centralize healthcare. That's what's happening. Common Core education, Common Core healthcare. That's where we're going. So that there isn't we're creating the average patient by policy. We're all the same. But that's not where the science is taking us. The science is taking us into the world of precision medicine to provide the right care at the right time. And so you heard today, if you were listening carefully, to the various presidents of the National Medical Association, the Asian Physicians Association, the Association of Black Cardiologists, what they were saying to you is there's something wrong with those measures, that they don't recognize our community in those measures. They don't see us. And what's crazy about that is we're the majority. I mean, I'm sorry, but we're the majority. And so how can you build a healthcare system that cannot provide optimal care to the majority of Americans? That's bizarre on the face of it. And so when I was sitting at Dan's meeting and I was listening to this, Dan can tell you, I said, Dan, we gotta have a conversation about this. We've gotta bring this to our community, to you, and say, is that what you want? Is that the kind of health care that you want? Do you want to have a system that cannot recognize that you're different and you need the health care that's appropriate for you? So that's what this conversation is about. And that's the conversation we've got to have on the Hill. That's the conversation we have to have with CMS. That's the conversation we have to have with organized medicine, all right? And there's another piece to this conversation about we're different. It's the clinical trial conversation. Because the clinical guidelines, that recipe that says, how do you treat a patient with diabetes, how do you treat a patient with hypertension, myocardial infarction, et cetera, it comes out of clinical trial data. That's where we get the science. And so if you're not in the clinical trial, it is not possible for us to know the safety and efficacy of the medication that you're about to receive. And so the way we did it in the past, we would wait until the clinical setting. We'd wait until you go in the clinical setting, and if you had a bad reaction, we'd aggregate up how many people had a bad reaction, and we say, well, we probably should be giving it to patients that look like that. But that patient and his family, guess what? They had the bad reaction, right? And so we partnered with pharma to start bringing diverse populations into clinical trials. Very important conversation, because in the minority community, you'll hear about Tuskegee. And my response to that was, that's a whole different generation. That's a completely different world. We're in a new space. And in the space that we're in, we are setting the future, we're setting the agenda, here's what we need to do in the space that we're working in. And so we have to say to our community, yeah, the past was a terrible thing. It was a horrible place. But we got through it, and now we have to look forward. So that's why we did that whole session on clinical trials today. It wasn't accidental, because we've got to get you into those trials so that at the moment of care, the moment of care, we know what's appropriate therapy for you and your family and your children and the next generation forward. So this is not really an academic conversation. This is a conversation about, in 2020, 5 years from now, 40% of the US population is minority. Today, the majority of people under the age of 18 years old is minority. So if you want to treat people under the age of 18 years old in the United States today, you're dealing with minority populations. And so if we want to have a healthy workforce, if we want to compete in the global marketplace, if we want to have a military, all of those things where we require our citizenry to participate in, we have to build a healthcare system that has the capacity to provide optimal care to Asians, to Hispanics, to Native Americans, to African Americans, to white Americans. Don't have a choice. That's the nature of the system that's before us. And so that's why I think this conversation today is so really important, because if any one of you live and work in the healthcare system, you know that 15 years to get information through a healthcare system across the country and getting folks to adhere to policy, get patients adherence, is a moment in time. And that's our challenge before us. So I think this is an important conversation. I ask you to really pay attention, I think, and think about it when you go home. And next time you sit in that doctor's office and you start to write that script, you should understand that right now, there are probably 300 or 400 performance measures out there, and they keep cropping up all over the place. And he's just going by a recipe book. And unfortunately, you weren't in the clinical trials, and you're not in the policies from which he's writing those scripts from. Thank you.
Is it later? Yeah.
Yeah.
Mm-hmm. Okay. Good evening. I first want to thank Dr. Puckrein for the invitation to be a part of this panel this evening, and I want to commend the organizers for such an on-point topic. These are the kinds of conversations we must have. Under our topic this evening, I've been asked to particularly speak to biological diversity and disease presentation. Let me preface my comments by saying, once the human genome was sequenced, it is a new day in biology and in healthcare. And the value proposition that I submit to you, each of you this evening, is that there is no health equity without genomics. There is no health equity in the day of precision medicine without genomics. To stay within the time limit, I would like to kind of stay with my slides, because I see my slides and I just want to talk about the information there, but I really want to give you the core of the information so we can have that conversation that this town hall meeting is designed for. Okay, so let me move forward. Nope. Let me move forward. For the advance, please. Mm-hmm.
Try that green.
That's what I'm
That's
asking.
you on the mouse, actually. I think you're
Okay. Okay, all right.
You're on the mouse.
Okay, we have 3 points and 1 word for each point. First point is the reduction in the cost of whole genome sequencing with the proliferation of, you'll see this acronym NGS, which stands for Next Generation Sequencing, generated omics online databases. What am I saying there? When the Genome Project was initiated and the budget set aside to generate that reference genome, we talked a budget of $3 billion. So you may say $1 billion to get a representative or a reference sequence, or maybe the average genome, if you will, that wouldn't apply to any individual. $3 billion. The goal of the Human Genome Project was to get that cost down for sequencing the genome to $1,000. And within the span now of just under close to 15 years, the cost has dropped from billions to within thousands. And if we look at whole, what we call whole exon sequencing, and that's sequencing the part of the genome that codes for proteins, it can be done for 800 or less for the whole exon. So I want you to appreciate that the relationship between the cost of the technology and where we are today. The whole genome with its 3 billion nucleotides can be sequenced now for a cost that is certainly within the range of insurance coverage, providing the knowledge that comes from the sequencing, the physician will be able to use that knowledge in decision making for the care of that patient. For clinical translation to take place, not only must we map and sequence the genome and find all these markers, but we have to do the science for the physician to know how to use the knowledge from sequencing the genome to make decisions about the care of that individual, whether in the cause of the disease for a refined diagnosis or in treatment. Okay, big data then. Genomics has driven biology into the big data arena. Biology is now a computational science. And big data analysis of populations and personalized information on differences in DNA sequence variation is being used to unlock the mysteries of genes in health and disease. And we still talk about the differences between populations in terms of health disparities. But remember, after we reduce the health disparities, we still got the problem of the disease. And so the genome is the foundation for understanding. And the point has already been made. This year, 2015, is a signal year. Opened in January, as has been said before. President Barack Obama seizing the moment of the time to announce the Precision Medicine Initiative in his State of the Union. Just so we're all on the same page, just very quickly, genome, the complete set of instructions that each of us receives from each of our parents at the moment we begin this cycle of life as a single cell. We get one complete genome from the mom, one complete one, of course, from the dad. So we begin a single cell that has all the information for dividing and replicating its DNA to give these exquisite bodies that we love and cherish and want to preserve. Trillions of cells. We can just see the differences on the outside, and if you consider inside the diversity of organ systems, and yet each of those cells come equipped with the same genomic information. The only thing that distinguishes one cell from another is history and its location, which determines its environment. The genome story is the same for populations. Look at the diversity in populations. The only thing that distinguishes populations would be their history and their location, which defines the environment. The genome is able to adapt to whatever the environment is in order that life continues. So genomics is not your grandfather's genetics. Genetics looks at the parts and try to make inferences about the whole from the part. Genomics is a whole view. It is holistic, if you will. It is all of your genes working together in harmony and in concert to give you what you see. Some of the key, is that seconds remaining? Okay. That really frightened me. Let me go here. Knowledge is the word for today. The NIH in 2020 unfolded the BD2K initiative. BD2K, big data to knowledge. It has been said that every problem is a lack of knowledge. The generation, the raw data for knowledge comes from research. So all of the issues we've been dealing with in terms of research and being guinea pigs and what have you, genomics comes and say there are no spectators in precision medicine. If you are going to access this healthcare system, then you have to have your information presented. Now, we may have to change some things about how we do business, but the business of precision medicine is based on your genetic information. And if you're not in the system, even if you are 52% of the population, the information that the physician is going to use to determine what disease you have and what's the best treatment is going to be based on what's in the electronic databases that are generated, from which guidelines for how to diagnose and how to treat will be based. So we have some real conversation to have about clinical trials. Not just what's wrong with them, but how do we make them right? Because it is the best way to get at the knowledge base for whatever clinical problem we are trying to understand. I will just pass this quickly with the editorial. The Genome Center at Howard University was formed in 2001, commensurate with the first draft of the whole genome sequence. We came into being with a recognition at that time that diversity in the populations used for the Genome Project was non-existent. In fact, indeed, it was our director of epidemiology who was single-handedly almost responsible for collecting the samples from the Yoruba population in West Africa for the HapMap project. And the HapMap project was the first evidence to look at population variation after we got the reference sequence. It became very clear there was no problem with no diversity in generating the reference sequence because we're all humans, and every human can be a reference for being human. But once we had that reference sequence, there was no way to appreciate how to read that sequence, how to extract the information without an appreciation for variation in the sequence, because the information is structured in patterns of variation, and populations differ in their patterns of variation. This is key. You probably have heard this term many times, but single nucleotide polymorphism, the set of variations in the genome that was used to map the genome, to get your coordinates, to know whether you're on chromosome 1 or chromosome 12 and what end and what place, because we're trying to find all the genes that code for all the biological properties that we want to study. So these SNPs are markers for location in the genome. We went through the HapMap project, which showed population continentally distributed. Then the 1,000 Genome Project was a subset from HapMap, but sequenced entirely. So we had reference sequences from each of the populations. I want to put this one data slide here because this is key. What I'm showing you here, when we look at SNPs and we look at patterns, just look at 1 through 13 represent 13 alignment of these single nucleotide polymorphisms. And each alignment, 1, 2, 3, shows slight differences. What I want you to appreciate, of the 13, and we call these alignments haplotypes, of these 13, populations differ in the frequency of the different haplotypes. Haplotype 1 is haplotype 1, whether it is in African American, Nigerian, Hispanics, Asians. If it's haplotype 1, it's haplotype 1. Populations differ in the frequency. Now we use these haplotypes to map and look for genes. A haplotype is like a flashlight that we shine in the genome to look for what genes are in the vicinity of that particular haplotype. So I want you to appreciate that when populations differ in the frequencies of different haplotypes, which SNPs you use will be a key factor in your capacity to find the genes in that region. Notice that African Americans and Nigerian, shown in the red, have the highest frequency of haplotypes 1 and 2. So if we wanted to look for genes in the regions of those SNPs, then we would use the SNPs that are most frequent in that population. But notice that that same haplotype and those SNPs would not be what we would use if we were looking at Hispanics or Europeans. However, Hispanics as well as Europeans do show us a haplotype that's most common. This is key, and this is a factor because what SNPs you use determine your precision for being able to locate genes in the regions. Populations differ in their haplotype. Now we got the whole sequence, so we can know exactly what nucleotide you have, and we can use that information that's based on your genotype. This variation is so pervasive in genomic science that in 2007 it was declared the Human Genome Variation Breakthrough of the Year, variation, that researchers came to recognize the extent to which our genomes differ from person to person and the implications of this variation for deciphering and decoding genetics. So here are the facts summarized from the project. The Human Genome Project ushered in the era of genomic medicine, characterized by molecular diagnosis and classification. The human genome sequence variation can be used to individualize and to personalize population risk, yielding genotype-specific risk assessments in complex disease. Another mention, gene expression can be used to identify environment-dependent phenotypic variation in complex disease. Folks, health disparities require that we stop the competition between is it the gene or is it the environment, because they are one and the same. You cannot have a gene without an environment, and no environment can have an effect without a gene that it is interfacing with. So we need new models that don't compete one against the other as to where we should put our forces. We need new models for how to look at genome-environment interaction and be able to parameterize or measure the contribution of each to make decisions about where we will invest our resources to try to eliminate disparities or correct disease or treat patients effectively. That leads us to the very statement you've seen. So this will be the statement that will carry through the evening. After decades of research, we are poised now to enter a new era of medical practice where detailed genetic and other molecular information about a patient's disease is routinely used to deploy effective patient-specific remedies to treat it. We are about to enter the era of precision medicine. Cancer is the poster child for precision medicine. These are the facts where the data are there with regard to cancer. And as we see in cancer, the promise is for all diseases to the same extent. It's just that cancer is out front in demonstrating how we use the knowledge of the genome to diagnose and treat. So innovations such as the next generation sequencing and the Cancer Genome Atlas have revealed that cancer comprises hundreds of distinct molecular diseases. One person's breast cancer is not the next person's breast cancer, the next person, because there are multiple pathways that are involved in giving the clinical presentation. And it is imperative that we identify the specific pathway, and not only the pathway, but the particular molecule in the pathway if we want to effectively intervene. And it has been done in cancer very effectively. Breakthroughs in understanding the molecular biology of cancer have led to an unprecedented number of new targets in oncology drug development. Progress in the identification of biomarkers yields more efficacious and potent treatments, reduced toxicity, adverse drug effects, and the selection of responsive elements. Also, advances in molecular techniques make it possible to profile. Now, this is true cell profiling to identify the culprit, but to profile and characterize cancer on a molecular basis. Cancer is a genomic disease. And from that, we move on to early clinical successes with targeted therapies. And let me quickly move to an end here. I just want you to, the successes we have in cancer, that's why the president put money in the cancer development, because those promises are there for all disease, diabetes, hypertension, because all of them fundamentally are, the genome, it will give us information. But I want to leave you with this one thought. This area here of, we've done tremendous in terms of niching clinical phenotypes and environmental factors, but the area now is cultural factors, what people believe and how they think. And that coincides with the BRAIN initiative, which is before us. The biggest risk factor in health disparities is behavior. We need to understand why people make decisions that they make about their response to their environment. And so the message this evening, we need clinical trials, but we need to understand behavior. And therefore, we must do the genomics of culture with the same precision that we have done other aspects of the environment. And we have to participate if we're going to get the effects in these clinical trials. This is now genomics to society. As genomicists reach out to study the world's population, recognizing and respecting cultural diversity is critical to realizing the Healthy People 2020 goals of health equity. The multicultural nature of Africa and the African diaspora provide unique opportunities to apply genome-based tools and techniques in investigating the contribution of culture to health equity in precision medicine. The distance that we have not been able to solve, we will not be able to get to unless we recognize the role that culture, what a person believes about what is real, the role it plays. So the critical questions now, this is the next to the last slide, the critical questions are, what is the link between genes and behavior? How does our genotype interact with our environment to produce behavior? What methods are available to investigate these questions, and what are the societal and philosophical, ethical implications of discovering such links? This is the last slide, and this brings us to our discussion here tonight. This is a transformative science. I would have you, the reality is human genome gives us unprecedented opportunities for medical opportunities, commercial promise. Genomics is $1 trillion business already, and it is not even in the height of its log phase. This is not only big science, this is big business. And our engagement needs to recognize the challenges of economic empowerment. This is an area where there's room for education at all levels. And there are opportunities for these banks and genomic banks that I would like for us to discuss, because you cannot sit on the sidelines of precision medicine and expect to get good health. So there are ethical dangers for sure. There are social challenges for sure. But knowledge comes to solve problems. And because the genome has been sequenced in our day, it's time for us to solve the problems of disease and health disparities in our communities. Thank you.
Well, I think the wisest thing for me to do would be to sit down. Thank you. Good evening, and I think I'd like to begin my presentation simply by thanking Gary and the forum for once again taking the lead on an issue and saying not good enough. What I'd like to focus on is something we just recently published called Genes, Culture, and Health. And we very purposely didn't call this our genetics report because for us it wasn't just about genetics. It was about genes, it was about culture, and it was about health. And it's that environment together that we need to really be talking about. Here's the promise. Dr. Collins talked about genomic research as an epic drama that he hoped would produce health benefits for all the world's people. That's the promise, but here's where we are. When you look at genome-wide association studies, 96% in this day and age are of European descent. If this is the future of science, if this is the future of medicine, if this is the future of health for this country, 4% is going to create a new disparity that we're going to take forward into the next generation unless we do something about it, and do something about it now. Now, why does this matter? Besides the issue of equity, it matters because it's good science. There's this kind of 5% rule. When you look at genes and you look at genetic variants, the genetic variants found in less than 5% of the population are those that end up being most significant in identifying and understanding disease risk and therapy response. So in other words, we are not going to make the discoveries, we're not going to reach the promise of genetics unless we have a full and robust participation by all populations in genetics research. This isn't a matter of only equity. This is a matter of simply good science and fulfilling the promise of genetics. And it has real implications. When you look at major disease issues and the major drugs by condition, you can see the drugs aren't working for a lot of folks. We're getting something wrong. You know, and I cannot tell you the number of times I've gone out and talked about genetics to our agency members around the countries, and I inevitably get a physician come up and tell me, look, my patients are compliant. That's not the issue. They listen to me. They do what I ask. The issue is, for a lot of them, the treatments aren't working. We are missing something right now, and genetics does hold the promise of unlocking a lot of this. We do know already from some of the research, when you look at some very common genes, for the Hispanic community, there is significant variation. And I also want to talk about the issue of heterogeneity. Hispanic isn't one population. For instance, if you look at the second gene that's mentioned there that has significant impact on cardiovascular and psychotropic drugs, you find a faster metabolism in Mexican Americans, but you find a slower metabolism in Dominicans and Puerto Ricans. And it's this kind of heterogeneity that actually makes Hispanics a very good study population around implications. I was so glad to see this slide in your presentation. we think genetics is the end answer. Once we do the sequencing, once we understand genetic variation, we've solved the riddle. We haven't solved the riddle. What really matters in health implications for genetics is how we interact with culture and the environment. It matters, and you know, folks will tell you, well, SCS, socioeconomic issues, don't matter once you've understood genetics. The exact opposite is true. We need to understand more and better about socioeconomic factors, because whether or not you live in a community that has high pollution, that may be what triggers the genetic variant that triggers disease. We can't understand the health impact and only understand genetics. We've got to understand culture, and we've got to understand environment, and that is the interaction that makes health. Now, this isn't new. You know, Hippocrates, a few years ago, said it's far more important to know what person the disease has than what disease the person has. We've got to understand the person, and I get so frustrated when I'm told, well, it's important, but you're hard to reach. Your populations won't become involved. Just in the sphere of genetics recently, we've continued to hear that. That's why we're at 96% versus 4% in genome-wide association studies. But we've already seen two major examples turn that on its head. One in the private sector with 23andMe, the genetic testing company. They partnered with Dr. Gates in the Roots Initiative, and in just a few years had 10,000 African Americans enroll and build a new genetic database. In just a few years. We just ended a 5-year initiative with NIH doing a new kind of model. Instead of having clinical study centers at universities, having them at community-based organizations, and in the span of 5 years, enrolled 16,000 Hispanics. The next time folks tell you it can't be done, it can be done. It can be done easily if you have the right people doing it, and you have the right commitment, and you have the right model. So I'd end with just this. This is the challenge, I think, of this century. But unless we move that percentage from 4%, we're going to create for the next generation a new disparity in health that is going to carry forward. But we have an opportunity right now to change that, to change the field and really create a future of medicine that includes all. If you want to learn more about the Alliance and what we're doing, you can get our new report on our website, hispanichealth.org. But you can also text, if you want later on tonight, the words inspire or innovate or engage. That's what we do, to 805-722. You can learn more about us. If you have more questions, feel free to give us a call. Thanks so much.
So we have some microphones around the room. If folks have questions, I'm going to please step up to the microphone and let's get this conversation started. I'm going to kick it off because with Gary and Georgia, two issues aren't squaring for me. You have the promise of the genome and the rate in which we are making advances, but we're not there yet. We don't all have an individual test that we can go get and figure out what medicines we need or what treatments we need. But we have a government that's very much moving to value from volume in a very fast pace. The Secretary of HHS wants to get to 90% value by the year 2019. So we have a bridge there where this push toward, we'd call it cookbook medicine, is going to happen faster potentially than we're going to solve the genome. So what do we do in this interim period? Gary, you want to take that one first?
So I think certainly from the minority community perspective, we have to resist. We don't have a choice here. I participate here in Washington, and I listen to it's almost ad nauseum, to be quite frankly, to hear we want to move from volume to value, but the definition of value is really skewed. It's a definition that doesn't recognize the science that is coming, doesn't recognize the demographic shift that is occurring. And part of it, if you actually go back and you follow the history, what you know is that this move to this new pay-for-value system really got started in the 1990s, and you could even argue as late as the late 1980s, where when government, particularly in Medicare, decided that that physicians were not practicing medicine to clinical guideline, and that government had a responsibility to make sure, in the case of Medicare, that the dollars that the federal government was expending in healthcare were used appropriately. And so the whole movement started around clinical guidelines. A lot of the idea of clinical guidelines really gets started in the 1990s, and it was funded by the federal government working with organized medicine. Along that way, government said, well, what we need to do now is we need to reimburse, because we need to force physicians to actually listen and pay attention to those guidelines. We shouldn't have those guidelines as just documents sitting out there. And government started around 2004, 2005, beginning to use the guidelines in performance measures to reimburse. What wasn't recognized was that the world was changing. Right when they were doing that, the very foundation of what they were doing was changing. So what we have right now is we have a reimbursement system that is completely divorced from the science system, and has a whole different set of metrics, and those metrics have nothing to do with diverse populations. And what they're going to do is bring new levels of disparities. And what's crazy about it is that those disparities are going to be visited upon the majority of the American people. And so you have to say, and I realize they've made a huge investment in these programs, and they're not going to want to change them easily and all that. But I think Congress has got to step in and take a look at what we've brought here, that we have to align that wonderful world that Georgia is describing to you, where we will be able to use very precise information to control disease, but we're not going to be able to do it if government is going to stand in the way and try to create one-size-fits-all when it doesn't work anymore. That's mine.
I couldn't agree more that, and you're very astute in terms of we've got a disconnect between the way business is done and how business will have to change if we want to reap indeed the potential. Because I heard it said one time, the definition of insanity, and many of you probably heard that, this definition of insanity, to keep doing the same thing and expecting to get different results. There is a way the business of medicine and health is done. And there's a lot, as you said, of investment in the system. The system is not designed to have a knowledge based on the collective of the individuals. We tend to define the individual by the population, because we've used the population of groups, and we've characterized the groups. As my physician friend told me very early on when the term personalized medicine was very popular, look, medicine has always been personal, okay? Genomics did not make medicine personal. So there was some hearing of that. That's part of the reason why the more appropriate term is precision, because that's really what it is at the precise molecule that's involved in the biological process. But what I'm saying, there's nothing coincident about the way things unfold. Appreciate what you said too about culture. I think the fact that we haven't applied the power of our science, technology, engineering, and mathematics, or STEM, to try to model the parameters in culture that impact the biological. What am I saying? That it is diversity that is the tool for discovery. We can study all of this information about the biology of the genome simply because of the variation in these 4 nucleotides. It is diversity that we see what's already there. And we can't really study something unless we have a way to measure it. Okay, so what am I saying? Health disparities is the key to solving the problems of disease, because you need the disparities to be able to see what the process is that's going on in the biology. What does that mean? We've got to change this paradigm about how we even look at clinical trials. We have really got to engage at the street level or grassroots level. The community has to participate with the research scientists in what is being studied. Really, the community must appreciate the power of science to generate the best answers or the closest thing to the facts, and use the science to answer the questions it would frame. I would love to see a situation where the community decides what it is that's variant in the population that they want to study, and work with academia, work with the researcher and industry, work with the university to use the science to answer the questions that are raised by the community about why the differences, and get involved in the study, because research cannot be a bad word. Research is the bedrock or the raw material for knowledge. And it's knowledge that we need to solve the problem. We've got to rethink about how we use science. I say to this generation, look, STEM is the new liberation front, as far as I'm concerned. And one more statement about the genome. All this beauty we have about all we've invested in the biology, I'm saying to you, culture says the bigger story of the genome is about identity. It's about our inheritance. It's about who we are. I often say to my students, in 2001, when we got the first draft of the reference human genome, 2001 was also the year that we had 9/11. Okay, our center came in May of that year. The common thread is, in February we got the sequence. It's the role of the genome in health. Our center at Howard came into being because of the lack of diversity in the mainstream of genomic science. Our mission is to do the science and teach the knowledge based on DNA sequence variation and its interaction with the environment. So the genome is also about community. What defines African American, Asian American, Hispanic? Think about it, at least. And also 9/11 showed us that we also have to think about who we are in terms of our beliefs, and what our cultural differences are just as important to our survival. So our survival is not just the health of our body, but it's the perpetuation of our communities, and it's the stability of our world. And the genome has come to address all those levels. And my only point is, we have to be engaged in using the science. Flip that thing. Flipping is popular now. So we flip it where we use science rather than fear being used by science.
A question?
Yes, my name is Renee St. Anthony. I'm a physician by training, a public health practitioner by passion, and the Deputy Director of the Center for Reducing Health Disparities at the University of Nebraska Medical Center. So I've been coming to this meeting probably for 7 years now, and I love it because I look around the room, and sorry, every single hospital I've worked in, it doesn't look like this. So we are the choir. And what you presented today was very innovative, but the choir is not here, and we still have people in our choir, people we work with, colleagues, whether they're PhDs or MDs, who we're still trying to convince that health disparities even exist. So now that we have things like genomics and we can do precision medicine, we have studies that have come out and said even with evidence-based medicine of who should be referred for cardiac catheterization, or how to treat pain for certain ailments, and our colleagues aren't even abiding by that. As we progress, and we're going in the 21st century very quickly with this innovative information, how do we make sure that those who are most impacted by health disparities benefit from this science? So my question is, who holds people accountable? Who's the regulatory person or organizations? How do we ensure that ethics are a part of this innovative science? And then we talked a little bit about culture in the last conversations, and we talked about culture from the perspective of patients. But what about the culture of medicine and the culture of physicians? Even though here we seem to look like a majority, the reality is that underrepresented minorities who are most impacted by many of the disease processes that we've talked about, they are not represented in the medical or the scientific communities. So I'd like to hear a little bit more information from your perspective about that, please.
You know, when we started this conversation this morning, I said to you that one of the things that was sorely missing in the conversation was patient advocacy. And I want to unpack that a little bit for you in response to your question. So one of the real realities in our healthcare system that always get lost is that we actually pay for the healthcare system. I know insurance companies like to say that they're giving you it and the government likes to pretend. No, every dollar of every nickel, every penny in the healthcare system is paid for by the folks in this room, right? The Human Genome Project was paid for by the folks in this room. The Human Genome Project going forward is going to be paid for by the folks in this room. So the point I'm making to you is it's our collective responsibility. We can't say, can somebody else do this for me? Can I put this aside? This is something that we have to own. We in this room have to own it, right? You say this is the choir, well, we got to go figure out how to replicate and make the choir bigger. That's the conversation that we wanted you to get when we started off today. That's what we said. We're telling you that we have to build a healthcare system that has the capacity to provide optimal care for every American. Every American, everybody, right?
Possible.
Period. And that the folks who want to deny people access to healthcare, right? You've got elected officials who say people shouldn't have healthcare. They say it openly, and they get applause for it. You heard people say in a debate, if you can't get health care, what should happen? And they said, you should die. That's what people said, right? And the point of it is not that they said it, the point is, that's what democracy is about. Everybody gets to say whatever the madness is in their minds. It doesn't matter. You get a voice. So if you look at the information in the world that Georgia is painting for you and what that future looks like, and if that sounds inviting, if that sounds like the direction we ought to be going about and thinking about, then we have to work for it. It's not going to be given to us. It's not going to be handed to us. That's just the nature of the beast. I, for one, sign up for it because I know, and I come at this from the historian's point of view. You know, I'm not a physician, I'm a historian. My doctor's in history. And what I know is that African Americans were slaves, period. We were slaves in this society, and we had to fight that. It took us almost 200 years. It took us almost 200 years to get rid of that. We got out of that, and the system turned into Jim Crowism. And for another 100 years, we had to fight to have the freedom to go in the marketplace to buy a product. So we started off as the product, then we had to fight to be able to buy a product, and now we are at that moment where we get to define the world that we want to live in. And we get a chance to reach across to other communities, Asians, Native Americans, white Americans, and say, here's our vision. We're looking at the genome. We see the precise medicine. We're not even in the sequencing. When they were doing stem cell research, there were no minorities in the stem, there were no Hispanics, there were no Asians, well, there were Asians, but they weren't blacks. We weren't there. And I remember, I won't go into that story, but the point is that nobody complained. Nobody said, excuse me, how are you taking my tax dollars and you won't study me? I'm sorry, it's your tax dollar. If you don't want to be studied, you don't get studied. That's the way the system is. So my answer to you is, that's why we're here. We're here to start a conversation about the world we want to live in. We're at that moment. We're at that moment. And if we don't want to take the moment, then the world will be something that our kids may not want to live in. Because what we see is this contradiction in the system. We see the contradiction. Not only we see it, we are experiencing it. There are African Americans who are dying in the healthcare system right now because the system is not providing them standard of care. We can write the paper, we can publish it for you, we can measure that. But we won't go up to Capitol Hill and say that. We won't walk over to CMS and say that. We won't walk over to the White House and say that and demand otherwise. So until we get the political will, you get the government that you deserve. I think that's the answer to the question. That's my answer, sorry. Question.
Hi, my name is Marsha Martin. I work in HIV, and my question is to the whole panel, and I'd like you all, each one, to answer the question that I'm going to get to, but my question is really how, given that it's really hard to get even people to go get screened for healthcare issues, for people to participate in routine healthcare, what trajectory do you see to change the data that you presented across the board? If we're not participating in clinical trials, if we don't have the knowledge about where medicine is headed, if we don't appreciate where the science is, how do we grab a hold of this and change the trajectory? And I'm going to ask that of all of you, because I know that you each have one thing that you would offer to the public, you would offer to the providers, you would offer to the payers. But what would those things be? Because it's in a context of this reality where people don't participate in their health care. And what you are encouraging us to participate in is a level of understanding that is both simple and sophisticated. And we can't get people just to go get their blood pressure taken. We can't get people to routinely check their blood every day. So what is the one thing that you would put on the table that you think would change the trajectory?
Dr. Mullins, you want to start?
As you said that you work in HIV and AIDS, and many of us remember some of the early days when people did things like handcuffing themselves to Wall Street or doing things to get attention and demanding that something happen, right? And then we talk about asking people to participate. Well, if I'm asked to participate in something that I don't understand and I don't see it as being applicable to me, of course I'm going to decline to participate. But I think if we listened to what is important to patients and their healthcare providers, if we really listen, if we learn to listen, and if we answered the question that was important to the patient, not to the research community or the funding agency, that we wouldn't have to have this difficult battle of trying to engage someone because they would be demanding that they were involved, right? And so it gets back to that, is creating an environment in which people demand to be involved because they see the value in participation, as opposed to trying to provide an incentive for them to participate in something that I think is of value. And I believe that that's the part of patient-centeredness that comparative effectiveness research will address.
I'll just take a twist on that because I think Daniel brought up the patient-centered Outcomes Research Institute. And patient-centeredness is in their title. It's part of their mandate, and I think they've done a good job at that. But what you see primarily are patient advocacy groups. You'll see disease groups. They're specific to a particular condition that affects the population. And if we could replicate that for ethnic minorities and folks in this room who are interested in advancing the cause of race and ethnicity in research, that's a good model, but I don't think they've gone as far as they could in that area. So that would be one thing that I might suggest.
Well, I can say for me, as advocates, I think one of the best things we can do is change the idea of who can do science. Mm-hmm. When you look at the two most successful genetic registries right now, for African Americans, the Root study was led by a historian, Dr. Gates. For Hispanics, Hispanic Community Health Study, that was led by 5 community-based organizations. I think we need to change the idea of who can do science, and once we get those kinds of actors into the system, we're going to have much better outcomes.
Another question over here?
I sat for 2 days and listened to the NIH Precision Medicine cohort. And over the course of those 2 days, every genomic company, Anai, Verizon, Dr. Francis Collis, Kathy Hudson, and all those that are focusing on precision medicine were all there. However, as we can see, oftentimes there is no business entrepreneurial class to advance these causes that we're talking about. So if you're a chief medical officer of a pharmaceutical company and you are African American, you don't really have the ability to start a cohort specifically on African American genomic studies. So we are at a huge disadvantage in the 21st century, African Americans, because our business class is disproportionately represented compared to other classes in starting genomic companies. So if we think the goodwill of corporate America is we're going to invest in your community, start companies for you to study your own genomics, then how can we evolve this? And I think the challenge for us today is we do not have a business base that has the ability we need servers, we need data center, we need data warehousing, we need infrastructure to fully sequence the data. And without having that infrastructure, we're asking, can we sit at the table? Would you consider our genomics? And I think that is a challenge for everybody in this room, and I also challenge those that are in positions of power. When you do see African Americans that present yourself in a business, incubate them. Incubate them for the community, because without that class, we're not going to be able to advance the genomics.
I really want to say amen to that. And it was part of one of the messages is this genomics is a huge arena for investment, both for education, for training, and for solving the problems. There is opportunity for new job creation, for training. I mean, this is the beginning, and like I said, it's just mind-boggling. It's $1 trillion business, and we don't even have all the pathways mapped out for the intervention and what have you. So I'm sitting here wondering, how do we capture the imagination and creativity of our young people to see genomics as a new arena for growth and liberation, quite honestly? I don't know, but if the young people saw this as an investment arena and put some of that creativity, because it's not only about, I realize, just working hard in the same mindset is really not going to get us there. We really have to create it, and I'm just thinking that to create, we have to begin with the statement that Gary asked. Can you, first of all, believe that we can have a system that will be fair for everyone? And if we can't believe it, we can't have it. And so we have to ask individually and collectively in our community groups and in our homes, do we believe, do we believe that we can have such a system? Because if we can believe it, then the process, and it's going to be a stratified one, and each person works at the level that's most effective for them. Some of us are so vested in the system as it is not reasonable to think that their contribution would be in coming up with something new. So use each person for where they are in terms of how they can best contribute to the goal. And find the way that we capture the creativity, the power, the talent of our young people to see this as a new front for liberation of the mind, because that's really what it's about. It's not coincident that the Brain Initiative comes in at this point in time as well. It's about understanding the power of our thinking in our creating, and that we can't just we just got to look at it differently to do it differently. And there's some room for trying to fix some of the things that are fixable. But we've got to have whole new groups that are looking at new constructs, new ways to really capture this genome. Just let me leave this one thing. When I think about it, the genome has all the information about biology and our ability to adapt to any kind of environment. It's there, it's in databases now. How can we have contests or whatever we do to get people to come up with ways to mine this data for understanding these pathways, just like we mine it to try to find the pathological gene. I mean, I'm interfacing now with our theoretical physicists, and they just think differently. And the capacity now to look at this data and try to model it, to find patterns, to ask the genome, how do you do certain things? And then, I mean, if we can get our young people curious about it, maybe that's of the science. That's one thing I'm thinking we have to do, where genomics becomes conversation, become topics for songs and for just daily activity. How do we make this what we believe manifest? How do we bring it about? Because if we can believe it, I believe that saying, you can achieve it. But not unless you believe it. And we do have to ask the question, do we believe we can have a society and a health system that works for everyone?
I'd say two more. We've got two gentlemen standing. We'll take those two, and then we'll maybe adjourn out to the lobby, and we can continue the conversation. Sir?
Good evening. My name is Dr. Noel Cayo. I'm a physician by training. I work at the Montefiore Albert Einstein School of Medicine for NIH. I work in the SOL study, which is study of Latino. I am the study clinician there. So my question is, we explore many ways to address the disparity and the inequality, and we have brilliant presentation today. And the workforce, the physician workforce, my data from 2010 was 9%. The minority represent only 9%, and this number actually is 4% African American. Overall minority is 9%, and this number is trending down. So despite all the policy we can make and all the improvement, if the workforce, those who implement it, are reduced and are continue to drop down, how do you think this is going to be implementable, and what are we doing to augment the physician workforce in a minority? Today, I work at Einstein, and thousands of minority applying for primary care are being rejected because they said the board score is 90% to be accepted, and there's no data really correlating the board score and how a physician performs. So it's a matrix system that really has no bearing on the quality of the physician, yet they are using it to eliminate the majority or minority applying for residency. What are we doing for that? Thank you.
I mean, I got to tell you, I really appreciate that question, because we are absolutely right now throwing away a generation of promise. Our programs for medical school, our programs for study in the STEM fields, they have to do with the top 5%, there's programs, and for kids that drop out of high school. But the great middle that's at promise, we are doing very little for. And that is actually the model that we developed in our STEM program. We purposely didn't go for the kids that were, that were 4.0 and that were all AP classes. We looked on purpose for kids at promise. And we just actually last month got our 5-year first data from this initiative of how we supported kids, because Hispanic kids are the group of college students most likely to enter college and choose to major in a STEM field. But at the end of those 4 years, they are the group least likely to leave with a STEM degree. So we're losing all these kids. We put in a model where we showed if you look at kids at promise and give them some levels of support, we had, our graduation rates were 5 times what the rates were nationally for Hispanic kids going into STEM fields. I think as a nation, we have been willing to recognize those folks of the highest order, of the greatest achievement, but beyond those few high percentage points, all of these folks at promise that could transform our healthcare system we're missing and losing, and I think that's a really big policy challenge to get to the promise of genomics.
I would just add to that, again, reminding you that today, the majority of Americans under the age of 18 are what we used to call minorities. So I'm thinking about our country now. So now, if our country is not going to see that those kids get educated in science and technology, enter medicine and engineering, right? Where is our future workforce going to come from? What is, if you listen to the projections, what people are projecting, what they're projecting is there's going to be a decline in the education level of the American population. That's what's projected. They're not telling you that the reason why that decline is going to occur because of the diversity, the new diversity in America, but that's what's going to go on. And it's even worse than that, because as that evolves, you're going to create this caste society. And and you have to think about it when people say that they don't want to provide loans for colleges. You got to understand what they're saying about the future of the society. I mean, we're focusing our attention here on healthcare, but this is a real broad conversation about what the nature of this society is going to look like if we have the majority of Americans distinguished by race and ethnicity who are not going to college, who are not educated, who are not in the workforce. That's not an America that you want to live in. That's not an America that anybody wants to live in. So I think the challenge is not that particular part of the conversation. It's not a future conversation. That's a right now conversation. Because every day we're losing another generation. I mean, every second that's occurring. And so that there's a real immediacy about that, because come 2020, 25, who are going to be our physicians and nurses and research scientists and et cetera. So that's a huge problem.
I want to just add one thing to this. Your question was about physicians, right? And so I agree with this pipeline that we have to focus on. But what I notice is that you're right, that fewer than 10% of physicians are minorities. And yet when a minority physician comes along, we go back to that 9% and expect them to be the mentors, which means 91% of us myself included, would be given a pass at being a mentor. And to me, that's a tragedy. That 91% of people, who have become physicians or who have become mentors in some capacity aren't held responsible for also being a mentor. So that's another part of the solution. I agree with the pipeline, but it's also, we've got people who did graduate medical school, and what they need is somebody to mentor them. And that should be everybody's responsibility, exactly.
What is the one that graduated from medical school and now what's being done for them? What's their future?
Right, but I think it is. I think it's telling them the truth about what you need to do in an academic setting to get tenure. It's telling them in a hospital, what do you need to do to survive whatever the dynamics are there. And I think that we need to make sure that we treat an individual as having a mentoring team.
Yeah.
They can help them to become successful. And I think all too often there's a single mentor. It's not viewed as a group responsibility. And we go back to the overburdened people who keep getting asked to be mentors because there are so few, and it's a crazy model. We need to expand that team, and we need to hold everybody responsible for helping the next generation to be successful, not a single mentor who's already got 12 other people who have been asked to mentor.
Good. All right, we're going to finish up over here. Sir?
Bob Griss with the Institute of Social Medicine and Community Health. I'm confused. I hear that this panel is addressing the promise of genomic medicine, customized medicine. And I can understand that the sponsors of this conference see many growth opportunities in exploiting the science of genomic medicine. And I can understand how with personalized medicine there may be more effective treatments. But I also heard Gary say several times during this conference and previous conferences that a lot of the inequality in our society produces the disparate impact, the disparate incidence of all sorts of diseases. And I don't hear strategies to address that social inequality. That's regulatory authority. That's where democracy comes in. Why focus on how to be effective in treatment for preventable conditions to begin with? Is it because we're trying to figure out a way to unite everybody around the promise of genomic medicine? Don't we all have an interest in growing equality in this country? This country is the most unequal country in the world. And yet we're not focusing on those issues. That doesn't require a knowledge of genomic medicine. I was fascinated by the summary of it, and I'd like to learn more about it. But ultimately, the answer was, you've got to do something about culture. Culture has to do with politics. Culture has to do with Madison Avenue that creates those false consciousness in our behavior. And I think that if we're really interested in improving health of the society or of the world or of our community, we're not looking in the right place by talking about the promise of genomic medicine.
Please, may I respond to that? I think it's very important, particularly in this setting that we appreciate. I couldn't agree with you more in terms of genomic medicine. If that's what was being heard, I want to retract that. I don't take anything away from the power of the science to inform us, but I was also trying to make clear that we need literally a new mind about how to use the science to solve the problems that we must be a part of defining what the problem is. And how do we use the power of this science to solve problems that we define for ourselves? I just want to keep in mind, these genomes that we have, they've been sequenced, the information is there. It's about how life works. And while we're trying to develop strategies, the physicists now, we define the genome as an information and communication system that incorporates the most sophisticated of information technology in how it unfolds these bodies. We can learn from the genome. The challenge is, can we look at life through the eyes of the knowledge that's unfolded for us now in how the genome operates as a system, as an information? Can we mine that knowledge and then apply that knowledge and those principles in the things that we create, that we synthesize? How can we get folk interested in designing and bringing engineering into things we create that model what we learn from how the genome has done this successfully from the beginning of time to now? Keeping in mind that when we sequence the genome, one of the first lessons the genome taught us was the way you define yourself is grossly limiting and a major contributor to your health problems. The genome came to give us a view, if you will, of life from the inside out, contrasted with our whole system, which is largely based on from the outside drilling down to the genome. And the significance of that is we can get ideas about how to strategize to get certain ends from how the genome does it. So please, the idea isn't more information. Some of you in the audience of my ilk and heritage may understand what I'm saying here. It's tremendous knowledge, but knowledge is power, that's true. But the word is wisdom is supreme. How do you use the knowledge to solve the problem, and how do you get involved in defining what the problem is so you'll know how to use the knowledge? And the genome gives us a new fact-based, if you will. I like to say, even we say information-based for how do we solve problems. And if we get involved in what the genome says about how a system works, how a network works, how a pathway intersects and what have you, that's the kind of
I would just quickly add to what Georgia is saying from the social science perspective. The genome controls our behavior. I mean, that's the fact of it. And when they say we're an information system, that information, the program, the software that runs this system, runs your system, runs all of our systems, is that genome. And so when you start to think of sociology, you're really talking about the sociology of the genome. You know, when we talk about history, we're really talking about the history of the human genome. I mean, in fact, I mean, that's the point of it. When we talk about the science of human behavior, we're also talking about how the genome works in environment, internally, etc. So the world that we're entering, this is a whole different world. This is a world very, very different from the 20th century or the 19th century or the 17th century. This is a very different kind of world. And I think what we're saying to you, at least I'm saying, is that we need to make sure that diverse communities are a part of the unfolding of that in all of its standpoint. There was a point in time when it was appropriate, I guess, or society decided it was appropriate to exploit populations for labor. That's what they were doing, right? And so we've sort of outgrown that system. We've got lots of technology and machines. We don't need that stuff anymore. And so that's what we're arguing about. Not arguing, but presenting and saying to you that the way in which we're going to tackle problems in the 20th century, by the time we get to 2040, 2050, oh my gosh, a whole different animal. And if I had one complaint, my complaint, as I voiced earlier, is that I think government is slowing us down. I think at least on the payer side, on this innovative, how we reimburse for healthcare side of the ledger is really, it's old school. It needs to go. the paradigm shift has occurred. Thomas Kuhn, The Structure of Scientific Revolution, the paradigm shift has occurred, and we're on to something new.
Well, I'm going to wrap it up right there and thank all of our panelists and the audience that hung in there and had a long day, but a very important topic, and glad we had this opportunity.